Hello, my name is Dr. Mary E. Money. I'm a board certified internist and have been practicing in Hagerstown, Maryland since 1979. Today, I would like to present some information about palliative care and hospice. I know that this is a confusing topic for many people, so I hope this presentation will help to clear it up. Please understand that none of this information that is presented today should substitute from you talking directly with your primary care provider about medical conditions. This is a brief biography. I am board certified, and in 2021, I transitioned from primary care and established a consultation service for residents in Maryland through telemedicine. The goals for this lecture is to review what palliative care is. What is the difference between palliative care and hospice? I hope to help individuals understand when hospice may be an appropriate option for the end of life transition. And I want to provide valuable resource information for everyone and making sure that the end of life forms are understood and completed. The World Health Organization defines palliative care as an approach that improves the quality of life of all patients and their families facing a problem associated with life-threatening illness. And this is done by preventing and relieving the suffering by early identification of those problems and impeccable assessment and treatment of pain, other problems, physical, psychosocial, and spiritual. It is not just for the end of life time. Hospice is a type of palliative care, but palliative care covers several years before hospice is necessary. Now, why is this important at this time? We can see from this slide how our population is steadily getting older. And this has been increasing rapidly since 2015. So many more individuals who are over the age of 75 have complex medical problems for which palliative care could be quite helpful. If we look at the transition of care on this slide, I think this really helps to explain it. When a person presents to a primary care doctor, they are diagnosed eventually with a medical problem, and then curative care or treatment is instituted. But during that period of time, it's important to address any complications of that care by providing palliative care. It is only at the end of life, those last 6 months of illness, that hospice should be considered. But prior to that, all patients are eligible for palliative care. Now, hospice must, because of the regulations through CMS, it must be determined by the provider that the patient does not have a life expectancy of more than 6 months. So palliative care is more than just simply those last few days of life. It may include helping people manage pain, nauseousness, fatigue, other troubling symptoms associated with their illness or treatment. It should optimize their comfort and ability to function. It is still curative, so people will still be getting care when they're having palliative care because it provides support for depression, anxiety, stressors, relationships. In addition, it improves the care by coordinating communication and other health care providers. So the essential components of palliative care is building rapport with patients and family caregivers, managing the patient's symptoms, distress, functional status, educating the patients about their illnesses and their prognosis. This is all components of palliative care. Palliative care refers to relieving the symptoms of an incurable medical condition. So this could be complications of high blood pressure, complications of heart failure, complications of diabetes, peripheral neuropathy, complications of cancer treatment. But it's focused on easing the stress and improving the overall quality of life. Now, unlike hospice, which is only available for the end of life care, and that, as I've said, is really the last 6 months of life expectancy, palliative care can actually benefit tons of people at any age and at any stage of illness. It's an important consideration about insurance coverage. Well, insurance will cover palliative care because most of these things are included in a routine office visit or in the hospital care, and they may be part of the long-term care plan or chronic care insurance coverage. A consultation, however, may or may not be covered for palliative care, so you'll need to check with your insurance provider. It may include the post-hospital care, like in a skilled nursing facility and home health care. All of that is part of palliative care. So palliative care, again, includes good communication with your primary care provider and specialist, answers to your questions, control of your symptoms, improved quality of life, discussion about your goals and end-of-life choices. But it doesn't include a separate place for you to get your care unless you go to a skilled nursing facility following hospitalization. And it doesn't just include the care immediately before death. So we're talking about palliative care is important for several years before that terminal phase of your life. So what's the difference between palliative care and hospice? I hope I have explain part of this, but hospice is a type of palliative care that is covered by all insurances for patients and families who have been informed that life expectancy is now probably limited to less than 6 months, but hospice care can be extended beyond 6 months if the patient's condition continues to deteriorate. It is not care that's only given when a person is expected to die imminently, but instead is available for the transition phase that is expected to last at least 6 months, or 6 months or less, I should say, if the medical condition follows its usual course. So hospice is a type of palliative care, right? It is for the medical care for the last 6 months, but palliative care is appropriate for any chronic medical condition at any time. That is palliative care. So why are individuals reluctant to call hospice? Well, a lot of people think that hospice is only for those patients who are actively dying. That is not the case, please. It is available for people who are expected to have less than 6 months, but it's not just for people who are actively dying. There's a misconception that hospice speeds up the dying process. That is also not accurate. Hospice helps to alleviate the pain. It doesn't speed up the dying process. The goal for the hospice team is to provide the highest quality of life, alleviating pain while addressing emotional and spiritual needs. Hospice doesn't treat the illness, but maximizes the patient's quality of life in those final months. Additional points. It is not about giving up, but it redefines hope by helping patients and their families deal with the challenges during this phase of life. Hospice should be considered for any terminal problem and is not limited to the diagnosis of cancer, ALS, heart disease, liver disease, dementia, pulmonary disease. But again, a physician must confirm that in their best judgment, the probability is that the patient will have less than 6 months to live. It doesn't have to be less than a week to live, less than 6 months. In case a family is wondering when is it appropriate to get a hospice consultation, these are some of the points that you may want to consider. If your loved one is having numerous visits to the emergency room or hospital, they're not getting appropriate relief at this time, they're having increasing pain, current medicines are not working, particularly if your loved one no longer wants to have active treatment. So if someone has chronic kidney disease, no longer wants to have dialysis, this may be a good time to talk to a hospice staff person. If the family is having more difficulty trying to manage the patient at home Everything is getting worse. There's a failure to thrive. They're not eating. They're not feeling well. They're sleeping more. They're more short of breath. Then all of these are times that it would be appropriate to get a consultation from hospice. You don't have to wait until the patient has to go into the emergency room because of acute problem. Everyone in the family may benefit from hospice, not just the patient. Hospice will support the entire family through this process. Now, you do not have to have a referral from your provider in order to get a hospice consultation. All you have to do is call them. What prevents a family or a patient from calling hospice was actually accepting the end of life prognosis. No one wants to be faced with telling a person that they're going to die, at least no provider wants to. But by doing so, it allows that individual to have time to talk to their family members, resolve issues. How often have you known someone who has died suddenly and never had that opportunity to say goodbye or make amends? So if your loved one or if you yourself decide, I really want to have this time and it's getting shorter that you expect to live, then this will be the time to call hospice and get some help, get some support. What are the advantages of hospice? Hospice care is personalized nursing care, medical equipment, and supplies that are related to the individual's terminal illness that is provided at no cost to the family. The entire family can receive the emotional, spiritual, grief support during this transition phase of life. Hospice can immediately improve the quality of life for everyone, and experts have agreed that hospice is most beneficial when provided for a minimum of 3 months, but 6 months is ideal. And hospice care can be renewed if the process doesn't end the first 6 months and care is still needed. So you do not have to wait until you think that your loved one is going to be passing inside of a few days. That is not the case for hospice. Nor do you have to avoid getting additional support if your loved one is having a lot of complications. You can certainly consider doing palliative care for until the last 6 months. Now, what is difficult about talking about death? Everything is difficult about talking about death. None of us want to be faced with that information that we're going to be dying. None of us want to die. At least I hope none of us want to die. But it's an important thing for us to recognize and to accept. So talking about it is so important with your loved one. I mean, you need to talk with them. What do they want to do? Let's hypothesize for a second that you are the son or you are the daughter, and it's your parent that is ill. Well, what does your parent want to have done if they have a stroke, or if they can't walk, or if they can't eat, or they can't swallow? Do they want support? Do they want to just be made comfortable? What about if their loved one is in an automobile accident, has a head injury? Do they want to be kept alive in a vegetative state? What about if they suddenly have a cardiac arrest? Do they want to be resuscitated? Unfortunately, if what's on TV, what happens in real life when it comes to cardiopulmonary resuscitation is not the same. As we all get older, the chances for success with cardiopulmonary resuscitation is less and less. Age is the major factor. Anyone who is a senior in their 80s or 90s, the chances of being able to return home is probably less than 5%. Okay? So, and when I talked to my mother about this, she was in her 90s, and I said, "Mom, do you want to be resuscitated?" Her response was, "No, I don't. I want comfort care. I don't want to die twice. I don't want people pounding on me or putting a tube down and putting me on artificial respiration. No, I don't want that." What is reality is that there is very little conversation about this. The preferred place of death, as shown on this slide, over 60 or 68% want to die at home. And how do you die at home peacefully? With the help of hospice. Okay? Only 5% want to die in a hospice facility, 3% in a nursing home. The conversations about palliative care is very limited. Okay? So most of the patients do talk with physicians, but it's only 46%. Here you have 22% that don't do any conversation at all about even palliative care. So conversations about this is really important. If we talk about hospice, it's important for you to understand that not all hospices are equal. So you be sure to ask some questions. The non-for-profit hospices are established to fulfill the compassionate mission. They may choose to accept patients whether they have insurance or not and offer services that are not covered by insurance because it's important for the patient and their families. However, hospices that are for profit actually are in the business to make money for their shareholders. So they're also required to pay tax on the profits. And they may provide some care for family, but may limit what care is provided depending upon whether insurance will cover it or not. Okay, so it's important for you to say, is your hospice program a not-for-profit hospice, or are you a hospice for profit when you call someone? Get the details. Now, this is some resources for families in Washington County, which is the county where I practice in Hagerstown. This is the telephone number and the website for it, and you can have more information through the email. This is some information about the Hospice of Washington County. Fortunately, we are very lucky to have the establishment of Dewey's House that was established in 2017 to allow acute and advanced symptoms where patients could be actually in a home-like situation for individuals. And then Hospice of Washington County also has now extended into Pennsylvania, and we have recently established a life care health program, which is the palliative care organization for Hospice of Washington County. So this is a telephone number for you to call and for more information. And Hospice of Washington County is a not-for-profit organization. So they may participate or actually provide care for patients even if they do not have insurance. It's important for everyone to have completed end-of-life documents. In Maryland, this is the website that you should go to for you to complete your MOST form and for your advanced directives. If you have any other state, then this is the website to go for that, to find your information by state. Please understand that if your loved one has a terminal illness and has not completed documents, but have told you that they do not want to be resuscitated, if the emergency medical staff come to you, the emergency rescue squad, they are legally obligated to perform CPR unless they can actually visibly see what the wishes were and the document that was signed by a practitioner. And as I just mentioned, most states require that any type of an end-of-life document, such as do not resuscitate, be certified by a provider, whether it's a physician, nurse practitioner, or a PA. You have to check with your state as far as what is the requirement. Once you have a document, it's important for you to make several copies of it. One should go into an emergency bag if you ever need to go to the hospital and give it to the individual who is in the emergency room, who's going to be taking care of your loved one. Make sure the individual who is the medical power of attorney for the loved one has a copy, and put one on the refrigerator or on the headboard if it's a do not resuscitate form. You can always update these forms if you decide that you want to change and you want to have resuscitation efforts. So if you have questions, please feel free to contact me. I'm happy to consult with anyone on this issue. I've done it extensively over the last 40 years, and I'm comfortable in advising a patient when I feel that continued care may not be in their best interest. For more information, please call me. My telephone number is 301-824-9240, or you can go to my website, drmarymoney.com. Thank you very much.